Right, let's get straight into it. We're going to do a deep dive into the FOURIER trial, specifically the pre-specified subgroup analysis that looked at patients with peripheral artery disease. We're going to pull apart its methodology, really get to grips with the results, and most importantly, talk about how these findings should be changing our vascular practice right now. So let's frame the clinical problem. We all have that high-risk patient with PAD in our clinic. They're already on the maximum statin they can tolerate, but you know their risk is still sky high. So the question is, what's our next move? How do we really go after that residual risk, not just for their heart and brain, but for their limbs too? This is exactly what the FOURIER PAD analysis helps us answer. To properly deconstruct this, we have to use the PICO framework. It's the only way to systematically break down a trial and really understand the evidence. So let's apply it here. Okay, so first up, the population. We're talking about 3,642 patients with symptomatic PAD. These are our bread and butter clinic patients. The intervention, evolocumab, a PCSK9 inhibitor, added on top of their existing statin therapy. The comparison group got a placebo, but crucially on the same background statin therapy. And finally, the outcomes. The big ones were major adverse cardiovascular events, MACE, and for us, the really key one, major adverse limb events, or MAE. Right. Before we even glance at the results, we have to appraise the methodology. Can we trust these findings? Let's dig into the internal validity. The first thing to say is that this is a pre-specified subgroup analysis. That's absolutely critical. It means it wasn't an afterthought. And because it's part of the huge, well-designed main FOURIER trial, it inherits all its strengths. The randomization and the double blinding, our best defenses against bias, are completely intact. Plus, every single event, whether it was cardiovascular or limb-related, was adjudicated by a blinded committee. That's our guarantee against assessment bias. Now, with any subgroup analysis, you have to worry about the play of chance, the problem of multiplicity. Slice the data enough times, and you might find something that isn't really there. But two things make these findings credible. First, the effect was consistent. It didn't matter how you slice the data, the benefit was there, which is what those non-significant P interaction values tell us. And second, there's just a massive amount of biological plausibility. It makes perfect sense that aggressively lowering lipids in a systemic disease like atherosclerosis is going to have benefits everywhere. The median follow-up was 2.2 years. Now, you might think that's a bit short, and you'd be right if we were looking for long-term mortality benefits. But for the outcomes they were measuring, MACE and MALE, which are event-driven and tend to happen earlier, that follow-up period is actually perfectly adequate. So, we're confident in the study's design. Let's get into the statistics. The hazard ratios are what's going to tell us the real story about the size of the effect. So for major adverse cardiovascular events in the PAD group, the hazard ratio was 0.79. What does that mean? It means a 21% relative risk reduction for patients taking evolocumab. And the key thing is that the 95% confidence interval doesn't cross 1, which tells us this is a statistically significant finding, not a fluke. But this is the result that should really make us sit up. For major adverse limb events, the hazard ratio was a staggering 0.58. That's a 42% relative risk reduction. I mean, this is a genuine game changer. It's one of the first pieces of robust, randomized data we have that proves intensive lipid lowering actually protects the limb. And this table perfectly highlights the difference between relative and absolute risk. Our PAD patients have such a high baseline risk that even with a similar relative risk reduction, the absolute benefit they get is just enormous. The absolute risk reduction was 3.5%. That's more than double the benefit seen in patients who didn't have PAD. And at the end of the day, that's the number that really matters to our patients. And the evidence just keeps stacking up. Look at this graph. It shows a clear straight-line relationship. The lower you drive the LDL-C, the lower the risk of a major limb event. And look how far down it goes. The benefit keeps on coming even at LDL levels below 10. This completely demolishes that old idea that there's a point where lowering cholesterol further doesn't help. There is no floor. All right, let's distill all of that down. What are the headline results? The things you absolutely need to take away from this paper. So the bottom line is this. Adding evolocumab to a statin for our patients with PAD significantly and substantially cuts the risk of a major cardiovascular event. And we're not talking about a small, statistically interesting effect here. We're talking about large, clinically meaningful risk reductions. And here is a key examiner point. Do not miss this. The benefit wasn't just in patients who'd already had a heart attack or a stroke. It was just as strong in PAD patients who hadn't. This is so important. It tells us we should be using this therapy proactively to prevent that first major ischemic event, not just waiting until after it's happened. When you put MACE and MALE together, the composite endpoint, the absolute risk reduction is 4.1%. This gives us a number needed to treat of just 25. Now think about that. That means for every 25 high-risk PAD patients we treat with evolocumab, for about 2.5 years, we stop one major cardiovascular or limb catastrophe from happening. That's incredibly powerful, and we got all this benefit with no new safety signals. Okay, finally, let's put this into the real world. We need to think about how generalizable these results are and be honest about the study's limitations. The patients in this trial look exactly like the high-risk patients we see in our vascular clinics every week, so the results are very generalizable. Now, we have to acknowledge the limitations. Yes, it's a subgroup analysis, not a dedicated PAD trial, and yes, the limb outcomes were secondary, but they were prospectively defined and properly adjudicated. And let's be absolutely clear, this is an incremental benefit. Statins are still the foundation of therapy. Of course, there are real-world barriers like cost and access, but those are practical issues. They don't invalidate the biological effect we're seeing here. So, after all that, what's the final verdict? What is the actual impact of this paper on our practice?
So, does this analysis really change what we should be doing for our patients? Well, the answer has to be an unequivocal yes.
Here are the 3 core takeaways for your practice. Number 1, this paper proves that intensive LDL lowering is limb protective, not just cardioprotective. Number 2, this means we must treat symptomatic PAD as a coronary disease risk equivalent. It deserves the same intensity of lipid-lowering therapy. And number 3, this warrants serious consideration of evolocumab in our highest risk patients. I'm talking about those with polyvascular disease or those who keep having events despite everything else we're doing. To sum up, this is, without question, a practice-changing paper. It fundamentally alters our approach to secondary prevention in PAD. It gives us powerful, randomized evidence for a therapy that protects not just the heart and the brain, but for us, most critically, it protects the limb.